This conference will now be recorded.
Good morning. Welcome to the final ASNC virtual CV molecular imaging seminars. Today is the last session for the spring meeting. Before we get started, we have a few housekeeping tips for you.
I think you're muted, Sharmila.
Sharmila, you're muted.
Thank you. We have 4 presentations today and we'll take questions after all the 4 presentations are completed. Please post your questions in the chat box at the top of your screen and keep your questions and comments pertinent to the material. This presentation will be recorded and available on the ASNC website for viewing. The topic today is coronary microvascular dysfunction, and we have 2 outstanding teams of researchers presenting their work. The first team is from Dr. Rob Beanlands' lab. Dr. Beanlands is well known to all of you. He is the Weird Chair and Chief of the Division of Cardiology at the Ottawa Heart Institute. He is also professor in the Division of Cardiology in the Department of Medicine and Radiology at the Ottawa University. His research interests include cardiac metabolism, flow, and cellular function. He has conducted multiple research trials in various settings, including the Part 2 trial, the IMAGE-HF trial, the Canadian Atherosclerotic Imaging Network trial. Dr. Beanlands has received many honors and awards, and we are very proud that he was a 2019 president of ASNC. He has published more than 300 peer-reviewed articles. He's a career investigator supported by the Heart and Stroke Foundation, and he received the CIHR ICRH 2019 Distinguished Lecturer Award in CV Sciences, and he's also a recipient of the Herman Blumgart Award. Sorry, my slides are not advancing.
Sorry for the glitch. I think we're waiting for the Sharmila to come back. She had some problem with her slides, so we can start again in a few minutes when she comes back. So it's Mehran Sadeghi. We're waiting for Sharmila to come back, but if she has problems to connect, we may. Oh, she's presenting.
I think I agree with you, Miran. We could just get started with the presentations.
So
and
Sharmila says, yeah, Sharmila says that she's presenting, but we're not hearing her. So there's a technical problem here. Let me just double check with her, and if she cannot, if we can't hear her, we would start with the presentations and then go with the slides after that, the introductory slides.
I don't see her connected to this.
Yeah, I don't either. So maybe we should start with the Christiane Wiefels presentation. Oh, Sharmila came back. Oh, it's Christiane. Okay. And then when Sharmila comes back, we will get back to her. Sorry for this glitch. Christiane, why don't you start? You are from the Ottawa group, from Dr. Beanlands group.
You're muted, Sharmila. I mean, Christiane.
Christiane, you have to unmute yourself.
Can you hear me?
Yes.
Yes.
Okay. So good morning, everyone. First of all, I would like to thank ASNC for the opportunity of being here today to present some of the research that we're doing at the University of Ottawa Heart Institute. I'm a fellow in cardiac imaging. I have no conflict of interest in this presentation. Those are the faculty members of our cardiac imaging department, led by Dr. Chow. And on the right, you can see some of our staff collaborators from interventional cardiology and heart transplant. I will talk today about the research that we're doing on flow quantification. I will start talking about microvascular dysfunction in diabetic patients, cardiac allograft vasculopathy, and my colleague, Dr. Ahmadi, will then present his study on delta flow. It has been previously highlighted in Dr. Kemichi's presentation last week, but I'm here just to remember why it's important to know about microvascular function and flow quantification. First of all, the microvasculature is the main site of regulation of myocardial blood flow, and it's part of the disease process in multiple pathologies such as atherosclerosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, HFpEF, and cardiac allograft vasculopathy. And PET flow can define the physiologic significance of a stenosis involving the entire spectrum of disease, from microvascular to advanced diffuse CAD, and adds incremental prognostic value and potentially directing therapy. So everyone knows that FFR has the capacity to evaluate the epicardial vessel, while MFR, myocardial flow reserve, has the capacity to evaluate the entire vascular bed, and is calculated as the ratio of the stress flow to the resting flow in a given territory. It has been well demonstrated, and people in the audience have seen this thousands of times, but it's important to understand that although they are linked, MFR and FFR do not assess the same processes, and they play a complementary role. Mainly when you have discordant FFR and MFR, and you will have with abnormal FFR and normal MFR predominantly epicardial disease. And when you have abnormal MFR and normal FFR, we'll have predominantly microvascular disease. So this is just an example of an epicardial vessel with normal flow and normal pressure, and FFR will be normal of 1. When you have a focal stenosis, the pressure distal to the lesion will drop, and when it's below 0.8, you will have an abnormal FFR. And this is mainly due to flow separation and convective flow acceleration after the lesion. And then you'll have a drop in pressure. However, when you have diffuse atherosclerosis, the pressure distally to the lesion will be very similar to the pressure proximal, and FFR will be nearly normal. So this is what's happening when you have microvascular disease and you have this diffuse atherosclerosis in the microvasculature, and the index of microcirculatory resistance will increase in this region, and the pressure proximal to those microvasculature will increase as well, and you will not have this drop in pressure as you have normally, and the FFR will be normal as well. However, when you calculate the myocardial flow reserve, it will be reduced. So this is what Dr. Chong is studying here in the postcard trial, is the coronary physiology and its relationship to anatomy in patients with diabetes. So diabetic patients tend to have more diffuse CAD and associated microvascular dysfunction compared to non-diabetic patients. So this previous study from our group showed that diabetics' flow reserve decreases more rapidly with increasing extent and severity of epicardial disease. And a multiple linear regression model was developed to predict MFR based on clinical risk factors and imaging results. So we can see that age and mainly female sex, among other variables, were associated with reduction in MFR, independent of the combined extent of severity of epicardial disease. So the main hypothesis of this study is that the combined invasive measurement of FFR, MFR, and IMR in diabetics would allow the future selection of appropriate mode of revascularization. So the patient recruited for the study will undergo coronary angiogram with invasive measurement of FFR and IMR and MFR with PETs that will be measured in all three vessels, and OCT as well will be performed just to ascertain the presence of diffuse coronary atherosclerosis, plaque characteristics, and plaque burden. The expected outcomes are to provide evidence for a correlation from the cath lab-derived MFR measurements to those measured by PET scan, define the actual proportion of diabetic patients with one of the four possible status in their coronary vessels, just as shown in the figure earlier, and to evaluate whether physiological parameters measured by FFR, MFR, and IMR changes after coronary stenting. So moving to the other research that we're doing is cardiac allograft vasculopathy, which has been presented last week as well by Dr. Feher. And we know that the incidence of CAV is elevated early post-heart transplant. And normally the patient has diffuse lesions with diffuse luminal narrowing and intimal thickening when compared to typical atherosclerosis. And heart transplantation can be asymptomatic due to heart denervation. It's very difficult to treat, and retransplantation is usually the only option. So CAV is the leading cause of death between 1 to 3 years after transplantation, and still to date, invasive modality with coronary angiography is the standard for cardiac allograft surveillance. So Dr. Sharon Shi published in 2018 this paper evaluating the role of flow measurements and the diagnosis of CAV. And she showed that 3 of the PET variables were predictive for CAV. So myocardial flow reserve, stress myocardial blood flow, and coronary vascular resistance had elevated specificity and sensitivity for the diagnosis of CAV. And then she proposed this algorithm. And when you have all the 3 variables normal, so CAV is very unlikely, and the patient would benefit from non-invasive PET surveillance. And when you have 1 or more than 2 variables abnormal, CAV was considered possible or likely, and the patient would benefit from invasive coronary angiography and IVUS. This study was validated at the beginning of this year, and she was able to demonstrate an elevated sensitivity in both derivation and validation cohort when you had 1 abnormal variable, and elevated specificity when all 3 variables were abnormal. So multiple studies have evaluated the prognostic benefit of PET flow parameters in post-transplant patients, and Feher demonstrated last week the importance of serial evaluation of post-transplant patients, and how a low baseline MFR and a drop in MFR was also predictive of outcome. So this is our recent study with serial PET examination, and we aim to evaluate whether early post-transplant and longitudinal PET measurements of MBF provide prognostic information in this patient population. So we evaluated 121 patients undergoing 2 PET examination early post-HER transplant. So the first PET was at 1.4 year post-HER transplant and the second PET at 2.6. We followed those patients for 3 years. And one of our main results is that a reduced stress MBF less than 2.3 at baseline was predicted for adverse outcome. As well, a persistently reduced stress MBF had a trend toward reduction in event-free survival. And a persistently increased cardiovascular resistance was prognostic for outcome. So what are the future direction of our group? We're still working on flow assessments of diabetic patients and doing a prospective evaluation of serial PETs early post-transplant. We are working as well on flow and myocardial viability and the role of rate pressure product correction in myocardial blood flow. Thank you very much for your attention.
Thank you very much, Christiane. This is Sharmila Dorbala. I'm back again. I was presenting the intro slides, assuming all of you were hearing me, but not. So Joe, can you please make Dr. Sadeghi presenter? Perfect. Thank you very much, Meran. Apologies again. I have shut out my video. I wonder if that was an interference from that. In any case, I wanted to briefly thank everyone for joining this last virtual CV imaging seminar series. We have presentations from 2 major labs. Dr. Rob Beanlands, who's very well known to all of you. He's the chair and chief of the Division of Cardiology at University of Ottawa Institute of Heart Institute. He's a professor in the Division of Cardiology and Medicine. His research interests are on cardiac metabolism, flow, and cellular function. He has performed several multi-center imaging research studies. Most importantly, he was the president of ASNC 2019, published extensively, and has received several awards, including the Herman Blumgart Award from S&M. The next is Dr. Marcelo Di Carli, also well known to all, Chief Division of Nuclear Medicine and the Executive Director of Cardiovascular Imaging at Brigham and Women's, as well as Professor of Radiology at Harvard Medical School. His research interests include cardiovascular physiology and pathophysiology, molecular imaging, outcomes research. He has published over 300 peer-reviewed articles, also a recipient of the Herman Blumgart Award from SNMMI and several other awards. The next is an introduction of our first speaker, Christiane Wiefels. As you all heard, an excellent presentation from her. She's a fellow in cardiac imaging at the University of Ottawa Heart Institute. She trained at the Federal Fluminense University School of Medicine in Brazil, and she's a PhD candidate. Her research is focused on myocardial viability, heart transplantation, PET flow quantitation, and Christiane is a member of the ASNC Leadership Development Program from 2019. The next talk you'll hear about is from Dr. Ali Ahmadi. He's a research postdoctoral fellow in the Department of Cardiac Imaging, University of Ottawa Heart Institute, an awardee of the MITACS Elevate Fellowship. He's a previous awardee of the University of Ottawa Cardiac Endowment Fellowship for a preclinical study on myocardial metabolism in the context of pulmonary hypertension. The next 2 presenters are mentees of Dr. Di Carli, Brittany Weber, who's an advanced cardiac CV imaging fellow at Brigham. She's a T32 CV imaging fellow. She trained at the University of Pennsylvania Medical School and received a PhD in immunology. Her research is focused on understanding the inflammatory mechanisms that drive coronary microvascular dysfunction and increased CV risk in systemic inflammatory diseases. Her clinical interest is in cardiorheumatology and cardiac imaging. She plans to become an independent investigator. Dr. Wunan Zhu is a staff clinician at the NIH NHLBI. She was a T32 CV fellow at the Brigham from 2017 to 2019. She is currently with Dr. Nail Mehta's group at NIH. She did her general CV diseases fellowship at MedStar Washington Hospital Center at Georgetown, and her research is focused on myocardial dysfunction and remodeling in aortic stenosis, hypertension, and inflammatory diseases. So thank you all for joining, and thank you to the speakers. We will now proceed with the second presentation, Dr. Ali.
Ali, I think you have to unmute.
I unmuted. Okay. Hello, everybody. Thanks for this opportunity to present at the ASNC seminar. I'm presenting one of the clinical projects named as Delta Flow that is in progress at the University of Ottawa Heart Institute under the supervision of Dr. DeCamp, Dr. Beanlands, and Dr. Chong. As disclosures, the Delta Flow study is partially supported by Jubilant Drax Image. I'm also a recipient of MyTax Elevate Fellowship. The diagnosis of coronary artery disease or CAD is challenging if this is only based on angina symptoms, as it greatly depends on age, sex, risk factors, and comorbidities. The complexity can be even more if the different types of CAD are taken into consideration, that is global versus regional and epicardial versus microvascular. Hence, various diagnostic imaging techniques are being used for patients with symptoms suggestive of CAD. And in Delta Flow study, our main focus is rubidium PET perfusion imaging. And we are also considering angiography results when available, as I will explain later on. Rubidium 82 is generated on site. No need for a cyclotron, has a short half-life, and scan time, enables both dynamic and static imaging, and provides a good image quality. Just a quick reminder that myocardial flow reserve or MFR and fractional flow reserve or FFR are both used to assess the ischemic burden of CAD, as my colleague Dr. Wiefels has indicated. CFR is the term that is also used for MFR. It is already known that FFR-guided revascularization, whether this is for PCI or CABG, is associated with less major adverse cardiac events. On the other hand, PET perfusion imaging too has been shown to be useful in predicting the outcomes. Murthy et al. Have shown that CFR of less than 1.5 is associated with a substantial increase in cardiac mortality compared to normal CFR of more than 2. Taketti, a colleague, have also shown that patients with CFR of less than 1.6 would benefit most from CABG compared to PCI. This graph is also taken from an article published by our department. This study indicated that MFR of less than 2 can be used to identify patients with higher risk of heart cardiac events independent of their summed stress score. However, there are still knowledge gaps in PET-guided management of CAD patients, such as MFR changes associated with different CAD treatments are not yet widely and prospectively investigated. Relationships between PET flow and comprehensive invasive physiology parameters in patients with CAD requires further characterization, and also the possibility of identifying low versus high risk CAD patients for cardiac events based on post-treatment MFR changes needs to be studied. So to address these questions, the Delta Flow study is designed and being conducted at our institute. The objectives are to measure MFR changes 6 months after clinically indicated CAD treatments, to assess relationships between PET and invasive physiology parameters in patients who have also undergone recent clinically indicated angiography, and finally to study the impact of MFR changes on cardiac outcomes. Inclusion-exclusion criteria are 3% or more of LV with reversible ischemia, some difference score of more than 2, or 3% or more of LV with regional MFR of less than 1.6, and stress myocardial blood flow of less than 1.2, or FFR of less than 0.8. The exclusion criteria would be obviously any contraindication for PET, unstable cardiac outcomes, multiple comorbidities, previous CABG, CCS4, and heart transplant. At the University of Ottawa Heart Institute, rubidium PET perfusion scans are performed on a regular basis. Our group has also developed a software called FlowQuant that is an approved program for clinical measurement of myocardial flow rates. This is an output sample that shows rest and stress polar maps and the ratio between the two, which indicates MFR values in different LV segments. One outstanding feature of these reports is absolute quantification of blood flow, as opposed to relative. In relative scale, if one segment is ischemic, it stands out among normally perfused segments. But in case of global ischemia, it may falsely appear as normal, whereas in absolute scale, this is not a limitation. As mentioned, the Delta Flow study is an ongoing project. To date, 1,740 PET perfusion reports have been screened for the eligibility criteria, and 127 patients are deemed eligible. This slide shows the demographic, LV ischemia, cardiac risk factors, and Canadian cardiovascular function class of the eligible patients. In this graph, LV ischemia is shown as some different score on the x-axis, and the blue bar areas indicate the patients with severely reduced global MFR of less than 1.6. If severely reduced global MFR is considered as a potential indicator of microvascular disease, we have observed that it inversely correlated with age, but not with other cardiac risk factors in the cohort of patients who are deemed eligible for the Delta Flow so far. This slide shows the overall progress of the Delta Flow to date. The aim is to recruit 50 patients in each treatment arm. The green and blue areas show the number of patients recruited up to the present date. And finally, this is a sample of results which shows that ischemia was improved with revascularization, whether PCR or CABG, at follow-up compared to their respective baseline. So as conclusion, PET perfusion imaging can identify CAD patients with higher risk of developing cardiac events. There are still knowledge gaps in PET-guided management of CAD patients. Delta Flow is a prospective observational cohort study. It addresses a number of key questions about myocardial perfusion changes after CAD treatments, and is an important step towards the design of a larger multi-center comparative effectiveness or randomized trial to better evaluate MFR-directed treatments for CAD patients. Finally, I would like to acknowledge the exceptional help and support that I received from my supervisor and mentors, as well as the staff at our cardiac imaging center. Thank you very much for your attention.
Thank you, Dr. Ahmadi. Excellent presentation. Joe, could you make Dr. Weber? We'll hold questions until all the 4 talks are done. Thank you.
I think you're muted, Christiane. Or yeah.
Brittany. Yeah.
Brittany.
Okay, thank you guys. I will restart. So there are many diverse manifestations in which systemic inflammatory diseases affect the cardiovascular system, ranging from accelerated atherosclerosis, pericardial disease, valvular disease, and diseases of the myocardium, including myocarditis and heart failure. Today, I will be focused on the vasculature, specifically the microvasculature. Just a second, guys. I do not need to introduce the coronary microvasculature to this audience, but just to put this into context. On the left, we see a coronary angiogram showing the epicardial or macrocirculation. On the right panel, the top panel shows an ex vivo angiogram, and the bottom a postmortem cast of the coronary circulation, illustrating the abundance of the microvascular network, which is not visible at coronary angiography because of its limited spatial resolution. Furthermore, in the middle, I'm showing diffuse non-obstructive disease detected by cardiac CTA. Recently, there has been a lot of attention on the association between inflammation and non-obstructive atherosclerosis. Thus, to study the microvasculature and the diffuse non-obstructive disease, we most commonly use cardiac PET. Sorry here, my slides are just not advancing. There we go. We sought out to investigate the question of whether patients with systemic inflammation have elevated coronary microvascular dysfunction. One model system we chose to investigate was psoriasis. Psoriasis is a common chronic inflammatory skin disease which affects 2% of the population. On the right, I am showing you characteristic plaques that are typical of the most common form of psoriasis. It is well established that psoriasis is associated with an increased risk of CVD and increased prevalence of CV risk factors. Furthermore, prior work has suggested that even after controlling for these CV risk factors, there is an increased risk. However, the mechanisms by which psoriasis leads to increased CVD is still not entirely clear. On the left panel, I'm showing a highly cited figure from Dr. Joe Gelfand's group from the University of Pennsylvania that demonstrated an increased risk of myocardial infarction with severe psoriasis compared to mild psoriasis over different age groups. On the right, you see the overall mortality curve for psoriasis compared to the general population, and the bottom table demonstrates the adjusted relative risk for different CV outcomes based on severe or mild disease, together demonstrating the increased risk of cardiovascular complications with increasing severity of disease burden. So to address this question, we use the Brigham Cardiac PET Registry. With PET, we are able to obtain absolute myocardial blood flow to assess the CFR and microvascular function shown here. We're able to look for obstructive CAD with perfusion, the burden of atherosclerosis by coronary calcium measured by the CT, and the LV systolic function based on the function volume curves. In this database, we first excluded all patients with positive stress tests indicating obstructive CAD, LV systolic dysfunction defined as an EF less than 40%, heart transplant, or other systemic inflammatory diseases. Psoriasis and psoriatic arthritis were then identified with ICD-9 and 10 codes and then adjudicated by manual physician chart review. We then constructed a control population that were matched based on age, sex, diabetes, hypertension, hyperlipidemia, smoking, and a prior history of CAD. Here I'm showing a table at the top of the patients in our study, which included 62 psoriasis patients and 112 controls. You can see that the psoriasis patients had a very high degree of CV risk factors, and these risk factors, were matched for the control population. Despite a similar prevalence of CV risk factors, patients with psoriasis had an increased prevalence of CMD, defined as a coronary flow reserve or a myocardial flow reserve shown here less than 2, and they had an increased severity of CMD as shown in panel B by the histogram. However, it's important to note that this finding could be simply a reflection of an increased burden of atherosclerosis in psoriatic patients, and to address this important consideration, we then calculated the coronary calcium. Here I'm showing the qualitative method we use to quantify coronary calcium on CT scans with 0, mild to moderate, and severe calcification. The left video is a CT scan of a patient with no coronary calcium. The coronary calcium burden was similar in psoriasis in the controls, as you can see on the bottom here. In fact, almost 50% of the patients had no coronary calcium. These results suggest that reduced CFR was not simply a manifestation of diffuse atherosclerosis, but represents an abnormal microcirculatory response to stress in the psoriatic patient. In another disease model I've been working on this year, we asked the same question in lupus. Systemic lupus erythematosus is a multi-organ systemic inflammatory disease that predominantly affects young women. There is an increased prevalence of CVD risk factors as well as non-traditional SLE-specific risk factors such as inflammation, glucocorticoids, and antiphospholipid antibodies. The bottom panel is showing a review that demonstrated that across many studies, patients with lupus at all ages had an increased risk of MI or cardiovascular disease. Similar to the design I just walked you through, we addressed this question using the same method with adjudication by physician review and matching for age, sex, and all the cardiovascular risk factors. Similar to psoriasis, we found that in patients with lupus, there was a higher burden of coronary microvascular dysfunction and increased severity that was similarly not due to the atherosclerotic burden shown here in the right panel. Now, before I turn to talk about some exciting mechanistic work which we are now pursuing, I would like to walk through our working hypothesis model. So we have systemic inflammatory diseases. They're all unique, but they each have common overlap, including inflammation. This includes the adaptive immune system, the innate immune system, and autoantibodies, and these will be different within each disease. We also have traditional CV risk factors as shown here. This leads at the vasculature level to accelerated atherosclerosis, diffuse non-obstructive CAD, and coronary microvascular dysfunction. At the myocardial level, microvascular dysfunction leads to decreased perfusion, resulting in subclinical myocardial injury, decreased compliance, and ultimately fibrosis and remodeling. And taking that down to the cardiomyocyte, this ultimately affects the myocyte, leading into structural alterations that result in the syndrome of heart failure. So this brings me to our working model, which is just the pathway I just walked you through. The important question that we would like to address next is what is the mechanism of inflammation, and are there specific pathways of inflammation that mediate microvascular dysfunction? So I would like to end the talk today with two examples to tell you about some very exciting work we are starting that is investigating the mechanistic pathway of inflammation. In psoriasis, recent evidence demonstrates that IL-17 alpha, which is a cytokine produced primarily by Th17 cells, is involved in the activation and proliferation of keratinocytes, which ultimately leads to amplification of the pro-inflammatory signals in the skin. Blockade of IL-17 alpha or its receptor will reverse the clinical, histologic, and the molecular features of psoriasis in mouse models. Furthermore, medications that selectively target IL-17 or upstream IL-23 by a P19 inhibitor, this is required for the maintenance of the Th17 cells, are also efficacious in moderate to severe psoriasis. So we are incredibly excited to be able to test this mechanistic hypothesis with an open-label, single-arm clinical trial. This is work that I will be doing with my mentor and the primary PI of the study, Dr. Carli, and co-PI, Dr. Joe Marola, who's a double-boarded dermatologist-rheumatologist with a research focus in psoriatic disease at the Brigham. We will be testing the drug tildrakizumab, which blocks the P19 subunit of IL-23, so ultimately this blocks the Th17-mediated pathway. We will test whether patients with moderate to severe psoriasis have an improvement in coronary microvascular function detected by CFR from cardiac PET after 6 months of therapy. We will furthermore study the relationship between CMD and myocardial mechanics with echoes that are performed at the baseline and follow-up. This was initially set to start in March, but due to COVID, it's been delayed, and we are hoping we'll get started in the next month or two. A second trial I would like to tell you about is the LYRA trial, which is led by primary PI Catherine Liao, a rheumatologist at the Brigham, whose research is focused on cardiovascular risk and rheumatoid arthritis. This is an ongoing study that we have been involved in that is nearing completion, in which patients with active RA are enrolled and receive a cardiac PET and labs prior to starting a TNF inhibitor. For this study, it was Cimzia, and then they receive a follow-up cardiac PET scan 24 weeks later. We have preliminary results from the baseline data that I'd like to show you today. The RA patients enrolled had no history of overt CAD, which was part of the inclusion criteria, and they also had a very overall low prevalence of CV risk factors. This is not shown here. But what I am showing is that we observed that higher RA disease activity was associated with a higher degree of CMD, shown here by the linear relationship and the Pearson correlation. These findings support a model whereby inflammation may lead to increased CV risk through microvascular dysfunction. However, it does not provide which pathway. We next looked at the association of 3 key cytokines in RA, which includes IL-1 beta, IL-6, and TNF-alpha. These all have specific drug targets that are used. From these baseline data, we found significant associations between IL-6 and soluble TNF-R receptor, but not IL-1 beta or high-sensitivity CRP, a more non-specific marker, suggesting possible specificity. Similar to the MINIMA trial, the LYRA study will also determine whether CMD is modifiable after reducing inflammation. And so with these two examples of previews of avenues that we are currently pursuing, I'd like to stop, and I'd like to end and transition to my colleague and former lab member, Dr. Wunan Zhao, who will be discussing the relationship between coronary microvascular dysfunction with myocardial structure and function with patients with hypertension.
Great. Thank you so much, Brittany. And also I'd like to thank ASNC for this wonderful opportunity to present some of our work in these challenging times and making it so accessible for everyone. So just as an extension to what Brittany has been talking about, I want to shift gears a little bit and talk about the role of coronary microvascular dysfunction and hypertension. Next slide, please. So as we all know, hypertension remains a significant cardiovascular risk factor. It's been estimated that 32 to 46% of adults worldwide are affected. And from epidemiological data, we know that hypertension is the most common risk factor for heart failure. This is data from the Framingham Heart Study on your right that shows that the cumulative incidence of heart failure increases with not only increasing blood pressure, but also increase in age. Prior data has also shown that there's a causal relationship between hypertension and left ventricular hypertrophy. Although current guidelines do not support the routine imaging evaluation of target organ and damage because perhaps we think that LV remodeling is a late and heterogeneous finding. So I think that this provides a great opportunity for non-invasive imaging to help identify subclinical disease and also understand disease mechanism in this population. Next slide, please. So we know from prior studies that LVH portends worse outcomes, and it's thought that LVH is an important intermediate phenotype in the progression of hypertensive heart disease. This is also data from the Framingham Heart Study that show that as LV mass increases in both men and women, the age-adjusted incidence of both cardiovascular disease and death increases. However, despite these observations, the exact mechanism of this transition to decompensated LV remodeling and heart failure is unclear, although we do have evidence that myocardial structural changes are associated with CMD, ischemia, and fibrosis. Next slide, please. So it's been observed previously that coronary microvascular dysfunction is present in hypertension. There are multiple mechanisms for which it's believed for this to happen. Primarily, I'll focus on the vascular remodeling piece involving remodeling of intramural arterioles and interstitial fibrosis leading to decreased capillary density, as well as increased extravascular compressive forces due to increased wall stress and impaired relaxation. Next slide, please. So with this as background, we wanted to understand the role of CMD in hypertensive heart disease, and specifically the relationship between CMD and myocardial structure and function, and whether or not CMD can be used as a way to refine risk in this patient population. As such, our first hypothesis is that in patients with hypertension and no obstructive CAD, those with maladaptive LV remodeling will have reduced stress myocardial blood flow and myocardial flow reserve compared to those with adaptive LV remodeling. And our second hypothesis was that adverse LV remodeling will associate with impaired MFR, LV myocardial mechanics, and increased incidence of heart failure admissions. Next slide, please. The results of this study were recently presented at the annual American College of Cardiology annual meeting, as well as published in the European Heart Journal. Next slide, please. So this was a retrospective cohort study involving patients with a diagnosis of hypertension who had analyzable PET perfusion and transthoracic echocardiograms within 90 days of the PET. We then excluded patients based on the presence of ischemia of suspected CAD origin, low LVEF, not available BNP, pro-BNP, or troponin within 90 days of the PET, as well as more than moderate valvular heart disease, amyloidosis, hypertrophic cardiomyopathy, or prior heart transplant. Our final cohort consisted of 194 patients that were then divided into having adaptive remodeling or maladaptive remodeling, which I will expand on the definition of shortly. Next slide, please. So this is our imaging assessment of the cohort. All patients had either 82 rubidium or N13 ammonia quantitative PET perfusion. They also had transthoracic echocardiograms for LV morphology assessment and myocardial strain assessment within 90 days of the PET. So from the 2D transthoracic echocardiogram, we determined whether patients had normal geometry, concentric remodeling, concentric hypertrophy, or eccentric hypertrophy based on their LV wall thickness as well as their diastolic diameter dimensions. Those who were determined to have normal geometry and concentric remodeling were categorized as having adaptive remodeling, while those with concentric hypertrophy and eccentric hypertrophy were categorized as maladaptive remodeling. Next slide, please. Our primary outcome was the first heart failure hospitalization, and our secondary outcome was a composite of all-cause death, heart failure hospitalization, non-fatal MI, or stroke. The median follow-up was 8.75 years. Next slide. So as we can see from our baseline characteristics table, this was a middle-aged patient population with a mean age of 68 years. There were 44% males, and the median BMI was 32. We then divided the patients based on adaptive versus maladaptive remodeling. And what you can see from the table is that the distribution of baseline characteristics were very similar between the two groups, with the exception of the calcium channel blocker use, which was significantly higher in the maladaptive group. It is important to note, though, however, that the number of antihypertensives taken between the two different groups were similar. Next slide, please. If you look at the hemodynamics acquired at the time of PET perfusion imaging, what we'll see is that the baseline resting hemodynamics are similar between the two groups, with the exception of higher systolic blood pressure in the maladaptive group. The stress hemodynamics are similar between the two groups. If we then look at the PET quantitative myocardial blood flow data, we see that the patients with maladaptive remodeling had a lower corrected resting myocardial blood flow, so corrected for the rate pressure product at rest. The maladaptive group also had lower stress flows and lower myocardial flow reserve. Next slide, please. When we looked at the echocardiographic data for these patients, we found that, not surprisingly, those patients with maladaptive remodeling had more dilated LV dimensions, as well as thicker ventricles. They also had higher E to E prime as a reflection of diastolic dysfunction, larger left atrial volumes, and importantly, more impaired global longitudinal strain as a reflection of myocardial mechanics. Additionally, we saw that those patients with maladaptive remodeling had higher pro-BNP and BNP levels. Next slide, please. When we did our multivariable regression analysis, we saw that there was a significant relationship between the corrected MFR with the global longitudinal strain as a reflection of myocardial mechanics, with the average E to E prime as a reflection of diastolic dysfunction, and the log pro-BNP as a reflection of increased wall stress. Next slide, please. We then wanted to understand the role of coronary microvascular dysfunction in the pathway of LV remodeling and heart failure admission outcomes. So in those patients that have an abnormal MFR defined as less than 1.8, when they had concurrent maladaptive LV remodeling, so highlighted by the first red box, or abnormal E to E prime, highlighted by the second box, and abnormal GLS, these patients had significantly higher annualized rate of heart failure hospitalization. Next slide, please. And finally, when we did a stratify analysis based on adaptive versus maladaptive remodeling, we saw that the patients with adaptive remodeling, when they had both abnormal GLS and MFR, had a higher hazard of heart failure hospitalization, with a hazard ratio of 3.93. Interestingly, this relationship was not observed in the maladaptive remodeling group, suggesting that these early markers of end organ injury may not be so useful later in the disease process, but may be more useful in earlier disease. Next slide, please. So in conclusion, patients with hypertension and no obstructive CAD, impaired MFR is independently associated with abnormal subclinical LV systolic mechanics, diastolic dysfunction, and wall stress. The combination of an abnormal MFR and GLS was associated with a higher rate of heart failure hospitalizations in both the entire cohort, as well as the adaptive remodeling subset. Coronary microvascular dysfunction and impaired myocardial mechanics can thus help to refine hypertensive heart disease characterization and heart failure risk assessment based on subclinical target organ injury. Next slide, please. So there are many people to thank. So I'm going to do this on behalf of both Brittany and me. So first, I'd like to acknowledge and thank Dr. Carli for his phenomenal mentorship, and everyone else who's listed on this slide who contributed to making all of this work possible. Thank you, and we'll be happy to take any questions.
Thank you, Munan. This was a great set of presentations. It's Mehran Sadeghi. Let me start with some questions from the audience for a question for Dr. Wiefels, which is about the outcome of your patients with abnormal flow reserve in cardiac transplantation. Do you have any data on that? Any preliminary data at least? You are mute, Christiane.
I'm sorry. Yes, so unlike other studies, in our study, only CVR and stress MBF was predictive of outcome. So MFR didn't show any statistically significant results. We know there is a lack in established PET flow parameters cutoff in her transplant population. And we tried different previously proposed cutoff, but for MFR, we didn't find any significant result. And we think that perhaps it can be due to the short follow-up period that we had, resulting in low number of outcomes, and perhaps the different patient population. Our population had the increased number of patients with diabetes. That's what we are working on.
Dr. Beanlands, did you want to add anything there, or?
Yeah, so there does appear to be some prognostic value to the parameters that Christiane was mentioning. We are also starting to look at very early post-transplant. The reason being that there aren't a lot of interventions for this, so we want to find out if we can define it earlier, because that would be when you would change chemotherapy, or the immunosuppressive therapy for these patients, and potentially could impact the disease. Part of the problem is a lot of the studies, all of us have been looking at patients later on in the course when there's really not much option for the treatment. So getting the prognostic information now we know that the parameters predict prognosis, and we know that serial parameters also help us. The key now is, can we actually detect it even earlier and therefore intervene?
Thank you. A question for Dr. Ahmadi, which is related to the same thing. So, in fact, two questions combined. How did you define the cutoff? How do you define the cutoff for normal values in your study? Because there is so much variability from group to group. And is it your hypothesis that revascularizing epicardial coronaries will affect microvascular function?
To answer the first question, the inclusion criteria would be MFR of less than 1.6. That indicates a severely reduced MFR. There are some studies that shows that even MFR of less than 2 can be considered as abnormal. But for our study as an inclusion criteria, we chose MFR of less than 1.6. and a stress myocardial blood flow of less than 1.2, which indicates a severely reduced blood flow and myocardial flow reserve. In regard to your second question, if I got it correctly, you were asking if a patient undergoes revascularization, does that improve microvasculature? There are some evidence suggesting that when revascularization is done, more nitric oxide is delivered to microvasculature, and that can help with perfusion at the microvasculature too. Yes, revascularization, despite the fact that it's at the level of epicardial coronaries, it can help with microvascular disease.
Great. And by the way, these were all very impressive body of work, all four speakers. So for Dr. Weber, one issue in your psoriasis patients, so they are treated with different meds, and some of them are steroids, some of them are on new biological agents. How do you account for that in your study?
Yeah, that's an excellent question, and unfortunately, that was a limitation of the study. We were not able to. We did not have all that information from the psoriasis patients, since this was a retrospective from our PET registry. That was not available from the chart, so that was indeed a limitation. And just as there was a mix of both psoriasis and psoriatic arthritis, any patient with psoriatic arthritis does have psoriasis by definition, but it's thought that even maybe psoriatic arthritis has even increased risk. With the lupus study, we actually do have a wonderful lupus registry at our program, and so we do actually have medication that we were able to look at in that, but that is a limitation of the retrospective study. And then the prospective study that we're starting with Minima will be able to control for that, because all patients will be will have a period of a washout of where they wash out their biologics, and then they'll be starting the tildrakizumab, which is specific pathway we're targeting.
And that's great. So, and Munan, that was a very, very interesting work that you presented. So do you think that, what's the cause and effect relationship here in maladaptive remodeling and myocardial flow reserve? And how does this, there are differences in wall thickness, and how does that affect the interpretation of MFR values in your study?
Yeah, so I think this is a great question. You know, what is the chicken and what is the egg? You know, so to answer that, you know, I don't think we can really say for sure in this study, because it's a cross-sectional study, right? So it's not like we identified a group of patients at baseline who did not have any evidence of remodeling and then follow them over time with repeat, you know, MFR measurements. So I think it's really impossible to say, but my general feeling is that perhaps this is kind of a vicious cycle. So, you know, having remodeling and myocardial flow reserve abnormalities begets more, you know, myocardial flow abnormalities and LV remodeling changes. So I think in answering the second part of your question about measurements, so are you asking, you know, whether or not we're measuring just based on the echo, or are you asking based on echo and PET?
I guess it's a technical question about spatial resolution of PET and measurement of CFR when you have differences in wall thickness, major differences in wall thickness.
Yeah, so I'm actually glad that you brought up that question, because the part 2 of the study is actually looking more specifically at stress flows and its relationship as a ratio to the LV mass to determine whether or not the stress flow is appropriate for the degree of myocardial mass. And I think this was, and I think maybe you're alluding to part of this discussion from last week's session, where there was a disagreement about, you know, stress flows or MFR. Is it adjusted, unadjusted? Do you adjust for the rate pressure product at stress and or rest? And I think that that's work that we're going to have coming out shortly to try to address these issues.
And Dr. Carli, did you want to add anything?
No, I think Marcelo. It was a fantastic session where you know, we got the full spectrum of microvascular abnormalities and the importance of this in disease and in patient management. So I think I congratulate everyone for their presentation. They were fantastic and very complementary work. all across the different labs.
Great. So we have a few questions from the audience, but I would ask the speakers to sort of reply to these questions offline. I think Sharmila wants to wrap up the session. We are behind.
Yes.
Do you need?
Thank you. So Joe, could you please make Mehran presenter? I could not agree more with the comments. Really fantastic presentations for rising stars, molecular imaging and coronary microvascular dysfunction. We really look forward to more work from each of you. So when you're presenter, Mehran, could you please share the slides?
If I could just interject, I also thought the presentations were outstanding and really very topical. And we definitely need more work and data in these areas to understand both microvascular disease and the potential role of measuring flow and flow reserve and so on in these patients. Thank you to everyone.
Thank you, Rob. So really, basically, I just wanted to go back one slide, Mehran. I wanted to thank all of you for attending this seminar series, and most importantly, wanted to thank all the faculty and fellows from several major medical universities around the globe. We hope to continue this in the fall and expect to expand this list to more universities. Could you go to the next slide, please? Of course, none of this could be possible without the support from our fantastic ASNC staff, who, as always, pitch in as needed. Special thanks for this program goes to Veronica Parkand, Jocelyn Adamoli, Joe Reyes, and Jennifer Taylor Howell, all of whom have put in numerous hours to make this a program success. And of course, we are grateful the entire ASNC team shown down there under the leadership of Kathy Flood to really bring this kind of innovative programs to membership around the globe. Next slide, please. And I could not end this session without thanking co-organizers of this course, Dr. Mehran Sadeghi from Yale and Dr. Woonen Zhu from NIH. Really countless hours of phone calls and discussions. And this program is thanks to their vision. And thanks to each of you for attending. We hope to see you all in the fall. Just wanted to make an announcement that the fall program starts off with an NIH symposium, which will be organized the last week of September. So that will kick off the fall program, and we will send you more details. Please stay in touch. One last word for all molecular imaging researchers. Please apply for the ASNC Leadership Development Program. We are looking for rising stars to be future leaders in ASNC. Mehran made a comment that we don't see too many non-physicians. This is open to all PhDs, MDs, scientists, everyone can apply. So thank you so much. With that, I will close this session. Thank you all.
Thank you, Sharmila.